So there's a lot of different antibody-based treatment approaches in myeloma. I put them into two categories: the naked antibodies, which is more like Daratumumab or Elotuzumab, or the bispecific T-cell engagers, which is a combination of two antibodies, a fragment of two antibodies, one of which will bind to an antigen that is on the myeloma cell, like BCMA or something else, and the other one will bind to a T-cell in the patient and bring the T-cell closer to the myeloma cell so that there is cell killing. So Daratumumab has been FDA approved for several years now and was previously, commonly used in relapsed multiple myeloma. And now we're starting to see that used earlier and earlier. So at this ASH meeting, the GRIFFIN trial data were updated, which show that there's a trend towards improved progression-free survival as well with the use of Daratumumab quadruplet upfront. So I think as we see time goes on, we'll see a lot more use of Daratumumab upfront as well. Isatuximab is another antibody, and we saw some clinical trials at ASH presented. The GMMG HD7 trial was presented, which again showed that the quadruplet using Isatuximab had a deeper MRD negativity rate with induction than not using it. So that's one set of antibodies. The other ones, which are very exciting, are the bispecific antibodies, which include drugs like Teclistamab, Talquetamab, Cevostamab, and many other BCMA targeting agents. So some target BCMA, but Talquetamab targets GPRC5D, Cevostamab targets FCRH5. And at this ASH meeting, we had tons of presentation updating data about these bispecific antibodies. So almost all of them seem to have response rate that are ballpark in a very heavily pretreated population, about 60 to 70%. Again, it varies. They also have cytokine release syndrome, similar to CAR T-cell therapy, but less severe and less common. It's usually with the first couple of doses that happens. And that might be a challenge as these come to the clinic. They might have to, we currently admit patients on clinical trials, so we'll have to think about the logistics of giving them in the real world. And then there's also the risk of infections as time goes on, and these patients are heavily pretreated. But the data looks very promising, and I think we expect FDA approval of these drugs in the coming year or two. And then there'll be real good options for our patients who have heavily pretreated disease. And, with CAR T-cell therapy and bispecifics, those are great options for our patients.